So, when we talk about the physiological logic, why is capillary refill time over lactate when it comes to the Andromeda?
On one side, that's actually true what you're saying, that lactate is a signal that's, let's say, confounded by some aspects. For example, adrenergic stimulation, liver failure, etc., and also the kinetics of lactate through resuscitation shapes like a bimodal, let's say,
Not a
drawing
linear
or
one, it's a
curve.
curve there.
Yeah,
It's
no,
curve.
yeah. So probably if we still chase lactate in this second part of the curve, we're probably submitting patients into a burden of over resuscitation and more interventions that we know that sometimes are toxic or could have adverse effects. And capillary refill time, let's say, is a very sensitive marker that's determined probably by skin blood flow. And when the patient is under stress, this flow will be diverted from the let's say, non vital organs and will be uh, taken away. So what we're seeing in the skin, and there's a lot of literature on this, is also happening in the intestine or in the microcirculation. So there's some nice studies correlating cap refill time with microcirculatory blood flow or abdominal organ flow. So it's like a canary in the coal mine that is alerting us that we're having hypoperfusion in relevant territories. And also the kinetics of response of capillary refill time are quite impressive. And there's a study in France by Lisa Raya that showed that after 15 minutes during a fluid challenge, we see significant changes on capillary refill. So I think there's on CRT, there's a big corpus of evidence with that assesses not only increased odds of like a prognostic variable, but also that can help us track changes on the cardiovascular physiology.
So, is it a time to say bye-bye to lactate, or still lactate can guide us in certain subgroups?
Yeah, no, I completely agree with your second. I think that we should use all elements of judgment to make better decisions, and probably lactate will show us a trend. If the lactate is improving, you're going in a good track. But capillary refill time will be probably faster to take faster decisions. I always tell my residents that it's like if you're seeing a patient with diabetes, you'll see the glycated hemoglobin that's lower, but you do the glucose
You the
script.
you do
Yeah,
the
like you
PTCC.
have faster information. Yeah, so probably they're bringing complementary information to taking decisions.
So, as we went through the data, we realized CRT normalizes faster. That is 86% almost versus 61% with the usual protocol as compared to the PHR. So we all understood CRT is the earliest actionable perfusion marker in real world practice. So what is the message to clinicians who still distrust CRT? They don't believe in CRT as yet.
I would tell them to test it, to check it, and to see it at the bedside to create their own idea and see how resuscitation moves with the patient, how the different tissue perfusion variables move to make their own corpus of evidence if they do not, if they're, let's say, as skeptics of this technique, and also to integrate it to other, not to use it as a sole marker of tissue perfusion, to integrate it with central venous saturation, lactate, and you'll see how it moves and check.